that if you want to discuss or present a case, you can just go ahead and like put your name in the chat, and we'd love to hear you. Saturdays are really special for VMRs. We do a whole VMR that is dedicated for students and trainees who don't speak English as a first language. So we have tons of international, multilingual, and multicultural students, and they share a little bit about themselves, their country, and of course, we do amazing clinical reasoning discussions. This Saturday was actually quite fun. Instead of doing like a one case for an hour, we did 3 cases in the hour and just like a rapid fire. Do all of the clinical reasoning. We had 3 really interesting cases and very different cases as well. The first one was a 34-year-old female on active labor. She had previous abortions and she presented with hemodynamic instability and an elevated D dimer. And I think she also had like a PTT that was very high. And one of the highlights of that discussion was thinking, you know, all of the pregnancy like the emergencies in pregnancy and particularly during active labor. So for example, we tend to think of APS, catastrophes, but that usually occurs like in the first and second trimester and it's not really triggered by active labor. So when you have active labor, not, you know, you definitely have to think about, you know, amniotic fluid emboli and dissection, which was the final diagnosis. It was an aortic dissection. The second case was really different, and it was a 75-year-old male with lumbar spinal stenosis and a recent aortic valve replacement who presents suddenly with worsening of his back pain, urinary incontinence, a new systolic murmur, and an ischemic stroke. And I really, really like this case, you know, because we definitely had a lot of systems being involved, you know, with urinary incontinence and then a new systolic murmur and an ischemic stroke. And I think one of the biggest takeaway points that I took was, you know, when you're thinking about someone with a new synthetic valve replacement and the different organ involvements, always think about endocarditis and, you know, merantic emboli going everywhere, which was the case. So in this case, she had endocarditis, endositis, and the ischemic stroke. I really, really like that case. It was presented by Gerline. And then the last case, it was really short, but really powerful in like all of the teaching points. It was a 60-year-old male from the Andes who had previous cholecystectomy, who presented with a new hyperechogenic mass on ultrasound with no acoustic shadow. And, you know, he presented because of hyperbilirubinemia. And it was really interesting because the patient had a previous cholecystectomy, so even when you have previous cholecystectomy, you can't really rule out completely stones, which is the most common case of obstruction. But you know, you could rule it out with the lack of acoustic shadow, and then you know you're left with like a mass, like an extrinsic mass that is obstructing it extrinsically or something inside of the bile system, and it actually turned out to be an biliary ascariasis, which was really fun. So 3 times the fun, 3 times the learning, and we're pretty sure we're gonna keep doing this. Maybe not 3 cases, but maybe like 2. So you know, definitely check that out on Saturdays.
Okay. Awesome. Thank you so much, Maria, for that awesome discussion. Greece has volunteered to serve as a discussant. Rafa has a backup case.
So would anyone else like to be a discussant tonight?
Interesting. Your body has a case.
Oh, I am so excited. It does not have to be a complicated one. I actually prefer that it's not complicated. complicated case and totally just totally tripped me up. So, Gurbani, that sounds awesome. And then Dr. Centaur has offered to be another discussant. And then anyone else who would like to discuss tonight?
And for those of you who are first timers, we encourage you to come in.
It's a lot of fun, really low pressure. We just get to learn and enjoy clinical reasoning together. So I highly suggest it. Awesome, Rafa. We would love to have you discuss. So Drew, do you want to take the first aliquot with me? And then Rafa and Uncle Bob, would y'all like to pair up?
Sounds
Absolutely.
perfect to me.
Awesome. I'm so excited about this. Gurbani, are you ready?
Hi, I'm just gonna try to log in to get some details, but I can give you the presentation as it came to the ED. This was a patient that I had recently admitted and followed through their hospital course.
Okay. Well, maybe while you're logging in, I feel like this is a pretty small group tonight and we know each other pretty well, but does everyone want to just introduce themselves quickly and maybe say one fun or interesting fact about themselves?
I guess I can start. Hi everyone, I'm Drew. I am a soon to be PGY1 at Western Michigan University in MedPeds. For those of you who saw me very briefly on Saturday, you may have wondered why I had gauze around my nose and or why I was absent from Friday. And I got a septoplasty and inferior turbinate reduction done on my nose, so now I can actually breathe better. Nose is starting to clear, but throat is still a bit sore. So hopefully I'm still at the top of my game in terms of discussing, but
Drew, I knows you will be. Okay, and then Rafa, would you just give a quick introduction?
Hi everyone, my name is Rafael and I'm a last year medical student here from Brazil. And it's always great to be here and to learn with you all.
Uncle Bob, would you introduce yourself?
My name is Bob Centaur. I went to the Medical College of Virginia about 50 years after I went, well, 45 years after I went there, Drew went there. I like to play golf.
Awesome. And then I guess a fun fact for me, I just got back from Blowing Rock, North Carolina. So I'm excited to be back and discussing. Gurbani, would you like to introduce yourself quickly?
Yeah, hi, my name is Gurbani. I'm a third-year medical student, currently on my medicine rotation. Fun fact, I have I'm co-parenting 2 cats with my roommate right now, and we're having an ongoing battle to see if we can convince one to like pick one of us over the other. And I'm currently losing right now.
Well, best of luck with that. Okay, I am excited to get started.
Give me 1 second, sorry. Okay, so this is a 86-year-old guy who presented to the emergency room with a concern of bleeding when he went to the bathroom, when he pooped. He recently had a colonoscopy because for like surveillance purposes, that was notable for some like advanced polyps. And during the procedure, had the polyps removed. And he also, like, this procedure was complicated by a microperforation. So basically, once the polyp was removed, they saw a target sign. And so then an immediate endoscopic repair of the polyp was done. And then immediately he was seen to have some bleeding, but it was addressed with some clips, and he was noted to be stable. And so then next day he presented to the ED with some right-sided chest pain just for the past hour, and then a little bit of associated shortness of breath, and then he had noticed some blood in his stool. But he doesn't endorse any sort of symptoms of like lightheadedness or anything else. I can stop there.
Drew, what are you thinking?
All right, so we have an elderly gentleman who recently had a colonoscopy complicated by a microperf that was clipped. Now coming back and presenting with bright red blood per rectum, as far as I can tell. I guess I did want to ask Gurbani, when the patient came in, how did he describe the bleeding? Did he describe his stools as just black and tarry, or did he actually see bright red blood when he went to the bathroom?
So he said there was just like streaks of blood in his stool, and then it became like increasingly bothersome to him. It was like increasing in volume.
Okay. So, and then he also came in with shortness of breath and chest pain after that, but it seems that the big issue for him is the bright red blood per rectum. So, at first glance, the microperforation that was clipped is probably the immediate first culprit that we would think of, but given the fact that it was repaired and given the fact that he was stable afterwards, that may have reassured the endoscopists while he was there, but it could have opened up. Because he also had advanced polyps, there may be a colorectal cancer that they didn't catch that was further down in the colon that might be starting to bleed now. And that could present with more of a microbleed, but given that he had a colonoscopy and given that he had a washout, it may have started bleeding further. At this point, he's stable enough that we could probably maybe rescope him, but because he's not lightheaded, it seems like he was able to walk into the ED. But I guess I'm still a bit concerned that because this happened immediately post-op, I am I'd want to get this addressed and try to look for a bleed as soon as we possibly can. And since he just recently had his colonoscopy, it would probably be easy enough to get him back in.
Okay. So Drew, some of the things that you talked about are kind of first thinking about stability. When someone comes in with a GI bleed, kind of the first thing that we want to be assessing is, is the patient stable? And what do we need to do to stabilize the patient? Which is sometimes a little hard based on history alone. And so I think in the next aliquot, as we get more vital signs, looking at the blood pressure, looking at tachycardia, also examining kind of the extremities cool, clammy, any signs of shock or anything like that are going to help us answer that question about, is the patient stable? And so I appreciate that you're saying like, hey, when we're triaging, is the what this is the first step. And then after that, I agree with you. We want to be thinking about why is there bleeding going on? And the background that we have here about having a procedure kind of changes the way that we would address this differential, because if that background wasn't there, we would be kind of thinking about the most common cause. It seems like, at least when we got from the history, it's probably more like a lower GI bleed, although, sometimes swift upper GI bleeds can look like lower GI bleeds with bright red blood, because when we see upper GI bleeds, when we see melena, we're seeing the effect of the bacteria. So if it's a brisk upper GI bleed, sometimes it can imitate it, but it seems like in this case, it's a lower GI bleed. And kind of normally we're thinking about, they're young Meckles, although that's rare. If they're older, diverticular bleeds are very common.
Right. Yeah.
Hemorrhoidal bleed, is there cancer, malignancy, what's driving the bleed. And here we have a procedure. And so now we're thinking about, after procedure, what could be affecting the bleed. And so, it's common to get a little bit of bleeding after a procedure. But it seems like the fact that this is presented in VMR, that he's presenting with shortness of breath and chest pain, which with the temporal relationship, I am going to say that this is probably due to a significant blood loss, although we're certainly going to be kind of getting labs to see if that fits our hypothesis. We have to probably assume that there's been a really significant amount of bleeding here. And so probably more than the normal bleed. And so we have to wonder, is there some sort of anatomic reason why? Is there like a bleeding blood vessel that needs to be addressed? Or is there some sort of coagulation issue here? Would be kind of my two things I'd be wondering. And the coagulation factors, it's very easy to look at, first you want to think about primary, look at the platelets, and then you want to think about secondary, look at the APTT, look at the INR, and then think about things that can affect it, the BUN, von Willebrand's disease, other things. And then, we're also going to be thinking about an anatomical cause. So,
Right.
there's a lot of good stuff here, and I am excited to kind of hear more and think about how stable is a patient, and then what could be driving this bleed.
And Anne Marie, I just wanted to add, thank you for mentioning diverticular bleeds, because that was another thing that I guess I should have noted in my differential. Not only because of his age, but also the fact that he had to do this massive prep, and if he had to strain to get excess feces out of his colon in order to be able to be adequately prepped, he might have ruptured a diverticulum and caused a bleed.
Yeah. And then I guess, we'd be wanting to know why he got the colonoscopy for advanced polyps, and if we had a baseline hemoglobin, because that would help us kind of assess what was going on. So I'm excited to hear more, Gurbani.
Right. So in terms of his past medical history, he has a history of coronary artery disease. He had PCI and stents placed in his left anterior descending and posterior circumflex artery about 10 years ago. He also has had a history of a AAA renal artery stenosis. The renal artery stenosis, he's status post endovascular repair, and he's also had stents placed roughly 10 years ago as well. And then he also had stage 2 colon cancer, for which just about 5 years ago, he had a hemicolectomy. In terms of other medical issues, he's got a history of hypertension and BPH. In terms of surgical history, there's nothing else other than I previously stated. For allergies, he has no known drug allergies. In terms of his meds, so he was on aspirin, metoprolol, tartrate, and tamsulosin. For the family history, there was nothing that was contributory. I will hold off on social history, but in terms of health-related behaviors, He had a very remote smoking history several years ago. He stopped. Several decades ago, rather, he stopped. And then he lives, in terms of his alcohol use or any other substances use, he doesn't endorse any of that use. In terms of withholding social history, I just meant I wasn't going to share anything in terms of like that wasn't specifically relevant to his diagnostic course, not like anything to withhold in particular, just for HIPAA. And then in terms of his review of systems, nothing additional to add. In terms of, I can give you, so it's for his base, since you asked for the baseline hemoglobin, I can give that to you now. And so the baseline hemoglobin was 12.1. And then for his vitals, he was stable. So he was afebrile and his vital signs were normal at the time. And then on physical exam, he was well appearing. He had no evidence of scleral icterus or conjunctival pallor. Cardiovascular was completely normal. Lungs were clear to auscultation bilaterally. At this point in the chest pain, like I tried to like see if I could reproduce his chest pain, but his chest pain had self-resolved. And then his abdomen exam was just mildly tender to palpation in the suprapubic region, but no evidence of rebound or guarding. And his skin was dry, warm, and well perfused extremities. The only like thing that was notable was that he had some like baseline resting, like hand tremor and a little bit of like inattention. In terms of, so I think I'm sorry, I didn't like plan this out in terms of like a lot of, because I'm kind of doing this like without pre-planning in advance in terms of aliquots, but I think it'd be helpful to give you labs from now, or would this be a good stopping point to discuss?
I think it'd be fun for us to try to guess the labs.
Okay, we can stop here.
Don't you think so, Rafa?
Okay, so
you know that I want to.
Okay, so this is a 6-year-old male presenting with GI bleeding. So the first thing that I would try to do, just like MK said, is to see if the patient was stable or not, to see if he would need like intubation. But also I would look at the meds, and this patient has aspirin. So I would take it off from the list of medications for this patient. Also to see if there's any other medication that could be leading to this bleeding, like warfarin. And always there is like bleeding, I would also be interested in to see the platelets, because if there is low platelets, I would rule out emergencies first. So emergencies that comes to mind with thrombocytopenia, I would think about TTP, HUS, GIC, but also catastrophic APLS. And then I would also look at the PT and the PTT to see how is that. Maybe the clotting factors are not working properly. And we saw that this patient has chest pain and shortness of breath. So maybe it could localize to the heart, the problem that this patient is having. And then we saw that this patient has hematochezia. So I would think about lower GI bleeding or high volume upper GI bleeding. And there are many etiologies that could be leading to the lower GI bleeding. And we also said about angiodysplasia, diverticulosis, and colorectal cancer. But I also thought about IBD, because when it comes to IBD, they have like a very young or very old, like they have like this bimodal distribution. And also I would think about ischemia, since this patient has some cardiovascular risk factors. So I would think maybe if this patient is having weight loss, or we could think about, for example, chronic mesenteric ischemia. And I also am rest assured that this patient doesn't have, for example, resting tachycardia. So it means that he's stable, you know, so that's what I'm thinking right now.
So that's really good. I actually want to go back to the beginning. And that is, and this is one of my pet peeves, and I apologize if it's insulting, but chest pain means nothing to me if I don't have a description of the chest pain, and shortness of breath means nothing to me if I don't have a description of the shortness of breath. And so for me to even think about this case, I need to know how long he's had the chest pain. Is it different than he had when he had coronary artery disease? What does it feel like? How long does it last? Does anything relieve it? All the classic things. Same thing with the shortness of breath. Is it shortness of breath with exertion? Has he all of a sudden had paroxysmal nocturnal dyspnea? Does he have orthopnea? If you listen to the Curious Clinicians, did he have bendopnea? And I actually had a patient who had bendopnea. And if you don't know what bendopnea is, I highly recommend going to the Curious Clinicians and listening to that episode. It's fascinating. New historical findings since 2014. And I didn't think I'd learn new ways to think about heart failure. So all those things being said, I think like everybody else, I'm really interested in the hemoglobin because I'm wondering, is this bleeding enough to cause the chest pain and shortness of breath? And if that's so, even though his vital signs are apparently unremarkable, although we don't have any numbers, which makes me a little nervous, then I'm going to be much more concerned about how much he's bleeding, and he has a colostomy. And I need to know more about that colostomy. I mean, how much colon was taken out, and does he have a bag now, or was he reattached? And I'm trying to put all these things together, and I feel like I have the sketch and the framework of a house, but I'm missing some of the rooms. So if we could get some of that information, I think it would help us in our thought process. So you had a hemicolectomy?
Yeah, it was a right hemicolectomy. Sorry, I wasn't able to get a great history, and I paused before I revealed something that I'll reveal in the next aliquot about his hospital course. So, but that's why I wasn't able to get much of like your classic description of like the chest pain, shortness of breath, other than the fact that it was like, it started about an hour ago before he came in. And it wasn't like just really, he felt like it wasn't the same as like the chest pain that he had before his like MI. And in terms of like, I don't remember the details off the top of my head about the hemicolectomy, but I could try to dive into the chart for
But he was reattached.
I don't, let me see.
And I'm sorry, but I've been doing this for a lot of years, and I worry about these details to try to understand what's going on. So I don't mean to be aggravating when I ask these questions, but that's what I do at the bedside, and that's what I do with interns and residents. Is remember that Robbie and I have slightly different schema for chest pain. When I was a third year student, which was 1973, I was taught the 7 deadly causes of chest pain I could do something about. So I quickly go through my mind myocardial infarction, and myocardial infarction certainly possibility of his anemic. Could this be a dissecting aortic aneurysm? You didn't give me any of the classic findings, and you didn't tell me blood pressures in both arms. Could it be pericarditis with tamponade? Well, we got nothing to go for pericarditis with tamponade. Could this be a tension pneumothorax? I don't have anything to go for tension pneumothorax. Could this be pneumonia? I got no reason to think he has pneumonia at this point in time because he has no fever and doesn't have a productive cough. Could he have a Boerhaave syndrome? I don't have a good reason for him to have Boerhaave syndrome. And could it be a PE? I don't have a good reason for him to have a PE because he's bleeding. How long ago were the stents, and why is he just on aspirin? And I assume he's not on a DOAC for his stents, because I wonder whether he had a predisposition to bleeding. And it could just be hemorrhoids. I mean, he did as Drew said, he did a lot of pooping.
Yeah, I'm not finding any further information about the colectomy, but let's see.
I'm still worried that there could be a perforation of his colon, And if he's markedly anemic and he hasn't lost that much blood, I wonder if blood's going, he's not just losing blood through the rectum, but could he be losing blood into the abdomen? And so a low hemoglobin is going to be a big red flag for all of us. And I think that Dhruv and Anne-Marie implied that at the very beginning, and Rafa implied that. And so the next big thing is, what is his hemoglobin right now, and where do we stand?
Okay, yeah. So so his hemoglobin was 12.1, and then do you want me to continue, or
If it's okay with Anne-Marie, it's okay with me.
Okay, so at this point he had an episode of bright red blood per rectum, and so his blood pressure just dropped significantly, and I don't have the numbers off of the top of my head, but his hemoglobin downtrended to 9.6. And he was he had his blood pressures were hypotensive, and let's see, and then in terms of his further labs, sorry, doing a little bit of digging through the chart. So for his CBC at this point, his white blood count was 4.78. His red blood, or his hemoglobin was 9.6, as I mentioned. Hematocrit was 29.6, and then his platelet count was 149. For his renal panel, so sodium was 141. Potassium was 3.7, and then he had a pH of 7.3. Sorry, I don't know why I'm reading that. I don't know where it says. Sorry, one second. Okay. So I did sodium, potassium, and then his chloride was 102, bicarb 29, BUN was 9, and then his creatinine was 0.81. His calcium was 8.6, and then the albumin was 3.8, and mag was 2. And then he also had a CT abdomen pelvis at this point, which did not show any evidence of free air in the or any evidence of suggestive of a large colonic perforation.
Giovanni, do you have an ECG and like a troponin?
I don't have an ECG or troponin on him, unfortunately. At this point, like he was transferred to the ICU,
Okay.
and so we can go from there in terms of like what was done and there.
Were his like baseline ECG and troponins without ischemic changes?
Yes.
All right. So, well, we now have a change and a new set of results. So, bright red blood per rectum, his hemoglobin drops as we would expect. So, yeesh. Now we gotta figure out where this bleed is. The CT abdomen pelvis is showing us that at least there is no large perforation that we need to say, oh crap, he needs to go to the OR immediately. His basic metabolic panel is not really showing me much. His pH is low, but that's probably due to the fact that because he's bleeding, he's probably got a little bit of lactate in his system. And he's hypotensive. At this point, I'd probably give him fluids. I'm not, he's not up to the point, because I think the strict transfusion goals for patients with coronary artery disease are hemoglobin above 7. So I would probably think that we would not be transfusing him at this point, but maybe if he had another episode, we might consider it. But I think the next step, once we were able to get him a little bit less hypotensive, would probably be to re-scope him and see if we can find the bleed and stop it. I am still harping on the fact, and I think the past medical history of having stage 2 colon cancer is sort of increasing at this point, that this is a post-procedure complication, and but I don't know. I don't want to anchor too early, but at this point, the evidence is so overwhelming in terms of saying that this is a post-procedure complication. We just need to go back and fix it.
Okay, so I think, Drew, like going through the labs and everything, I think it's always helpful to think about how big of a drop was this. And so we have good evidence that we have a baseline of about 12.1, and it dropped really quickly to 9.6, which is, about 2.5 units. And that's, a lot of blood. And so I'm starting to get really worried about the patient. And one thing I always like to remember is, at least acutely, you don't always see, if you acutely lose blood and you lose blood really quickly, it's not always equilibrated. So that 9.6 might not actually be where the patient is right now. It might be a much, much lower number, just if it's like a really, really fast bleed and the hemoglobin hasn't equilibrated yet. So like when I hear hypotension, big drop in hemoglobin, I'm really, really, worried about the patient. And like my first thing is thinking about access. Do we have enough access? Fluids, let's volume resuscitate the patient and everything like that. And then, thinking about, active type and screen. When do we need to transfuse blood? Which, generally 7 threshold, but if they have active, like an active MI, then you go for the higher threshold of 10, which is kind of why the ECG information, troponins and everything would be helpful in this situation. And then, I'm thinking about, as Rafa mentioned, are they on any medications that could be contributing? What are their platelets? What are their coagulation factors? So Gurbani, I don't know if you have coagulation factors here.
Let's see. Yes. At this point, the PT was 13.2 and INR was 1.0.
So pretty normal.
Mm-hmm.
Okay.
And
so
then, oh yeah, sorry, go ahead.
Oh, no, go ahead. Gurbani, were you going to say something else?
I don't remember if I had said that.
So, because the other thing I'm thinking about are, do I need to give any products to help with hemostasis here, which, these are pretty normal factors. The platelets are greater than 50 in this case. And so it doesn't look like we need to be giving factors and everything like that. And then thinking about the other labs here, I don't see a whole lot of abnormalities like in the sodium and potassium. I if I calculated correctly, the anion gap is 10, so it doesn't look like there's an anion gap. The bicarbonate is 29 and the pH is 7.3. I haven't had a chance to do all the calculations, but I am wondering if there's kind of a mixed acid base kind of disturbance here. It looks like, if so, because the anion gap, if I calculated it correctly, was a non-anion gap, would be maybe a non-anion gap metabolic acidosis, maybe with some alkalosis, but I haven't had a chance to kind of plug in the number. So maybe Uncle Bob could help with that. And then the BUN to creatinine ratio, if it was greater than 30, that could give us a clue to an upper GI bleed. Although, you know, again, in this case, we had such lower suspicion, but that's just kind of a helpful thing to sometimes look at in this case. For the ABG, I would be curious about like what the CO2 was on that, because that would give us more information to calculate the acid base status here. And then, I mean, I agree with you, Drew. I'm really worried about the patient. I'd be talking with GI and trying to figure out what's going on. The CT was a non-contrasted CT. And so it gives us less information here. So I think it's always good to think about things in the context of what it is and what are the limitations of your study. So, you know, if you're worried about a GI bleed and you think that VIR might need to evaluate on something, you want to get like a contrasted, usually there's a special protocol, like a GI bleed protocol, where you can see if blood is actively extravasating. Because, you know, in this case, I'm wondering, is there something that needs to be actively embolized by VIR? Because usually a colonoscopy is not usually an emergent procedure. You know, if it's an emergent procedure, usually it's done by, like, if there's something actively extravasating, it's done by VIR under embolization. So, you know, that's kind of what I'm thinking about, is like, is there something that would need to be done? Or thinking about, like, could this be related to the abdominal aortic aneurysm? Could there be some sort of fistula in place? And could that be causing this? Could this be anatomical related to the procedure? Could we have a retroperitoneal bleed, which we didn't see on the non-contrasted CT? So I think that's less likely, but you know, these are all kind of the things I'm thinking about. And so, you know, I'd be talking to the GI team, thinking about, do I need to get a contrasted CT, talking to the VIR team, and maybe to like the surgery team as this is going on and as I'm thinking about volume resuscitation. Uncle Bob, Rafa, anything to add in this situation?
Yeah, so there are a couple things about the labs. We don't know the timing of that pH with the chemistry, and if the pH was a couple hours later, it could be different numbers. The other thing, and
that's a good point.
The other thing that's really important is you can have a lactic acidosis initially with a normal anion gap. The lactate goes up before the anion gap goes up. I don't know why, but it's well documented in the emergency medicine literature. It's actually, if you worry about it. Now, let's assume an increased lactate. We could say that's just from the hypotension, just from the bleed, but given his age and given his history of atherosclerotic disease, you'd have to worry, could this bleed be due to ischemia? And could he be infarcting either his colon or his small intestines? And maybe we can see that on the CT, because we got a clue over in the chat that we haven't heard all of the CT results first. I probably would have done a CT with contrast in this patient. There was no contraindication to do a CT with contrast. As a matter of fact, there's almost never a contraindication to do CT with contrast, according to the nephrologists, because the CT with contrast doesn't use enough dye to put you at major risk for kidney injury. And I'd be typing and crossing and getting ready to give blood if there's enough. Assuming that the hypotension is due to blood loss, and you haven't really told us, is this a whole bunch of blood or just a little blood? But if it's a whole bunch of blood, I'm going to be trying to run in some kind of fluids to maintain the blood pressure and getting blood as quickly as I can, because exactly what Anne Marie was getting to is 9.6 is not a real number. This is sort of like when your creatinine's going up when you have acute kidney injury. You can't really estimate the GFR. We can't really estimate where this patient is ending up. For it to drop that much that quickly is really scary, because the patient probably with hypotension now is total body volume contracted. And so we got to get volume in, and that's going to drive the hemoglobin down. So all the things Anne Marie said, I think, are really important.
I was just gonna add that this patient, I don't know if Carboni didn't say to us, but I once read that when we had like AAA correction with prophylaxis, sometimes there can be a fistula between the aorta and the GI tract, and that could lead to GI bleeding. And I don't know if that would be possible here. And also, I would go, since once the patient is stable, I would actually go to endoscopy to rule out upper GI bleeding, because the CT didn't show me anything very interesting. And also a CT angiogram with contrast. I would be very interested to see that.
All right. So I can give you the next part of the CT that I didn't reveal before, but the other main finding was there was active arterial bleeding within the transverse colon at the site of the recent polypectomy, and it was likely from a branch of the middle colic artery. And so basically they had IR did an embolectomy of the terminal branch of the middle colic artery, and then he was also transfused in the ICU and stabilized, had routine serial CVCs, and then transferred back to the floor. And then once he came back to the floor, he had another bleed. This time it was a 200 cc blood loss, which was like worked up and found to just be a residual bleed from the embolectomy. But that was it for this case.
Awesome. Thank you so much, Gurbani, for stepping in and saving the day. And I know it's always stressful to do a case when you're not planning to and you don't kind of have everything all lined up, but I really appreciate it. And thank you so much. And there was so much great learning from this case. So everyone who participated, would you maybe just say something quickly that you like kind of learned from the case, or a reminder?
I think the big thing for me would probably be to I think I had a little bit of, I was a little bit too cavalier in terms of how concerned I was for this patient, especially considering when he came in, he seemed to be stable, but then after one episode of bright red blood for rectum, he became hypotensive. And then with his hemoglobin drop, I guess it didn't hit a threshold, but it was large enough that it should have triggered red flags. Oh boy, this patient's probably going to need fluids and transfusion now. Also that's dependent on EKG and symptomatic chest pain, especially considering his coronary artery disease history. So certainly being a little bit more conservative and thoughtful about making sure that we know that a patient is stable and not one event down the road to decompensating.
I think for me, the biggest takeaway is actually the management of GI bleeding. I think it's also very interesting to always remember that, and also the causes of the lower GI bleeding. So yeah, and I really enjoyed this case. Thank you, Gurbani, and thank you for stepping up and saving the night.
Yeah, I thought the learning point of just thinking about is something actually in equilibrium or not is just really helpful for me, and also always learn so much from Uncle Bob and his kind of rich history. So I really appreciate him stepping in tonight.
For me, the most important thing is the instincts that Anne-Marie has, because she's been through a residency that you don't get until you've been through a residency. At the smartest medical students are the dumbest interns. I've worked with brand new interns many years in the last 40 years, and they end up being brilliant physicians, and they really just don't have any instincts those first couple of months. And the instinct that Anne-Marie had about the hemoglobin dropping is an instinct that until you've seen enough cases, you don't have. And it says something about the importance of residency training and just seeing a lot of patients and remaining humble. And if there's any anxiety at all, always talking to your resident, always talking to your attending, because that's sort of that's really the big key. Once the blood pressure drops, then we all tighten our sphincters and we say, okay, what do we have to do, and what could be going on? I think everybody's instincts were right, and it sounds like at your institution that they said, oh, yep, this has to go to the ICU. This is a serious business. You just can't ignore low blood pressure. So I hope that's helpful. I hope that's helpful. But I love the way Anne-Marie described why she was very nervous at that time, and I think that for all the learners, the way she expressed that was just beautiful.
Well, thank you all so much for participating, and I am so excited to hear Maria's teaching points.
Hi, first of all, this was great, Gurbani. Thank you for stepping up and saving the day. I really liked the case because it gave us an opportunity to discuss treatment and like the evolution of the patient and not only the diagnosis. So we started having lower GI bleeding, and with this, you always have to define it, and that's gonna help you a lot, so we have like some definitions like rectorrhagia, not associated with defecation, versus hematochezia, which is associated with defecation, and those are like more red in appearance than melena, which is dark and foul smelling. And then you always have to think about the localization of the bleeding, and it's a big chunk of intestine you have to cover, but always do it step by step. So start with local disease, which can be ruled out like in the emergency, think about hemorrhoids or fissures, and then think about like the upper rectum or colon, which, you won't be able to do in the emergency room, but you will be able to get through imaging. So think about diverticulosis, cancer, angiodysplasia, IBD, or even ischemia if the patient has the risk factors for it. And you always have to think about upper GI bleeding, even if the patient doesn't have blood per like vomiting or anything, even if the patient has blood per rectum, you always have to consider upper GI bleeding, which is like fast and very severe in quantity. So don't rule out upper GI bleeding, especially when the patient is unstable, for like what Rafa commented about, aortic fistulas or very severe hemorrhages. And with the BUN-CR creatinine ratio, if it's above 36, that tends to localize to the upper GI as well. Always check if patient has adequate hemostasis system. So think about, past medical history. Is the patient prone to bleeding or like thrombotic events? Check for the drugs. Are they on any anticoagulation or aspirin or any sort of drug interaction between each other? And then check labs, platelets. You want to make sure the platelets are okay, the coag system is okay. And in any sort of bleeding, you have to triage the patient. So if the patient is unstable, you will always prioritize treatment over diagnosis. And I really like the pearl that after acute bleeding, the hemoglobin might be lower than seen on labs. So be wary if the hemoglobin starts to decrease, even if it's not like a big jump, because it might be lower than what you're seeing. And always this, of course, will come with time, but develop an instinct to worry when needed. And that will really be super important when you start treating these patients. And then, you have to develop that instinct, and you have to trust that instinct as well. You want to do the right image testing, and, you don't have to be afraid of contrast. Sometimes not doing imaging with contrast might be even worse for the patient than doing it with contrast. And if negative imaging comes at first, you have to do other imaging, because you can do like check the lumen and do endoscopies or colonoscopies, and you can also check the vessels with special tests like angio-CT. This patient also had chest pain and shortness of breath, and with these, you always have to characterize. So always remember all of the questions you learn at the beginning of med school. So you want to know the localization, the radiation, the onset, if it's worse with exertion. All of the questions you might ask might be very beneficial, especially in patients with chest pain and shortness of breath, because you definitely want to rule out morbid and mortal causes first. With chest pain, I really like the 7 deadly causes of chest pain. So you want to think, is this pain, does this pain seem like an MI or a dissecting aortic aneurysm, pericarditis with tamponade, tension pneumothorax, pneumonia, Boerhaave syndrome, or even a PE? And that, the story will tell you a lot. So yeah, that's like the summary of the case. We learned a lot. And I really, really like the discussion. Thank you, everybody.
Have a great night, everyone.